Welcome to another MedTech Gurus podcast, where we meet and discuss trending and educational topics that are important to today's medical technology sales and marketing professionals. Now, it doesn't matter if you're new to the space or if you're a seasoned medical sales and marketing professional. You all have come to the right place. You see, the medical technology world is ever-changing, and MedTech Gurus will help you stay up to date by interviewing experts and opinion leaders. Now, we call them gurus, and they will bring you information, techniques, and strategies that are sure to help you enhance your knowledge and help you bring value to your customers and your company. Now, I'm Sylvester Harris, and I'm pleased to introduce your host for MedTech Gurus, Mr. Tom Hickey.
Hey, what's going on out there, gurus? This is Tom Hickey, your host of MedTech Gurus, and welcome to episode number 292. Gurus, what if one of the most overlooked causes of hospital harm and cost was also one of the most preventable? Martin Burns, CEO of Bruin Biometrics, is a leader in predictive diagnostics, aiming to retire outdated wound care models. From the battlefields of hospital-acquired conditions to the boardroom of investors, Martin is on a mission to reimagine pressure injury prevention through biology-based strategies, AI-driven insights, and a handheld device that can detect damage before it breaks the skin. In this episode, we jump into how Martin transitioned from Deloitte consultant to a CEO startup, why prevention still struggles to gain traction in a treatment-focused system, the 5-step formula strategy that propelled BBI towards becoming the new standard of care, and why real innovation starts with listening, not just to data, but to patients and providers. This isn't just about better tech. It's about creating healthcare systems that don't wait for harm to act. You'll love the insights that Martin brings in this episode. But before we get into the episode, let's thank our sponsor, Accelerant Consulting. Gurus, the U.S. healthcare system is focused on value more than ever. With that, value analysis teams have become increasingly influential in product decision-making. Here's the problem. How do you help your product stand out to the individuals in the value analysis committee? Let's face it, if they have to come back and ask questions, it can set you back months before you get back on their agenda. How much would that cost you? Let the team at Accelerant Consulting help. They can review or even design your value analysis documents. The result being having a complete document that resonates with the professionals on these teams. Reach out to the experts at Accelerant Consulting today. Check them out at accelerantconsulting.com. That's EXCELERANT consulting.com and do it today. Okay, gurus, here it comes, episode number 292. And remember, if you like what you hear, please subscribe, leave a review, and most importantly, tell a friend. Welcome, MedTech Gurus. Today, as we mentioned in the introduction, we're thrilled to welcome Martin Burns, CEO of Bruin Biometrics, a company that's changing the game in pressure injury prevention. Martin brings an incredible blend of consulting, strategy, and innovation experience to the medtech world. Before joining BBI, he spent years advising Fortune 500 companies at Deloitte Consulting, and now he's helping lead the charge in predictive, preventable healthcare technologies. Under Martin's leadership, BBI has developed the SEM scanner, a handheld device that detects early-stage, pressure-induced tissue damage well before it becomes visible. His work is all about improving outcomes, preventing preventable conditions, reducing cost, and driving operational efficiency. Hey, Martin, are you ready to be our guru today?
Tom, I feel a bit embarrassed about the use of that term, but yes, I absolutely am, and I'm happy to join in the esteemed company that have gone before me, so thank you.
We're thrilled to have you. So tell us something fun or interesting about yourself or your family so we can get to know you a little better.
I had a very diverse background growing up. I was actually born in Zambia, right in the middle of Africa, and lived in Zambia, Liberia, and South Africa for periods of time, and actually was shipped out of Liberia in the dark of night while the military coup was taking place, and then left everybody behind there. And then we ended up going on a boat back up to England again and left everything behind. And I mention it because having been brought up in those countries in Africa and then actually going to live in ultimately in Northern Ireland, I was around enormous amounts of suffering, human suffering, and enormous amounts of inequality and inefficiency. And I have to tell you, it stuck in my gut. And so what happened in terms of the trajectory of my living and my career has been really heavily informed by those experiences. And I'm happy to share more about them. They are a little bit brutal in places, but I will tell you they have been very influential.
Yeah. I can see how that would happen. How old were you when you were had to exit during the coup?
So we left there in 1979, right at the end of 1979, and I was 7 years old. So old enough to remember being dragged out of bed at 3:47 in the morning and shipped off to a private airstrip to get out of the country.
Yeah, wow. Yeah, that would certainly leave an impression. That's for sure. So yeah, thank you for sharing that. But as I did my research, you made several fascinating transitions besides just that one. And for our purposes, the one of them that interests me is you went from a consultant at a major consulting firm like Deloitte Consulting to CEO of a startup, which had to be a little bit of a culture shock, I would think. What inspired that move, and what's been the biggest shift in your mindset since that change?
There are very few times in life that I have managed to identify a really big problem which drives health inequalities. That actually ties back to the Africa relationship, just drives health inequalities that actually anybody could have a profound positive effect on. And I saw this company called Bruin Biometrics on the front of the LA Business Journal back in 2011, actually, is when it was. And I was looking around at this thinking, this is extraordinary. This can't really be real. So I did the investigation. It was real. And I initially applied to be the chief operating officer of the business, which I ended up getting. And then shortly thereafter was promoted into the CEO role, which sounds incredibly sexy. But actually the reality was there was three of us. So, the small number of people. And we kind of went inwards to devise this strategy to be able to kind of grow the business from there and really grow the clinical research element from there, which is what we did. You asked about transition, going from a firm, which I loved, surrounded by people who were just wildly smart. And actually, the older I got in there, what I realized was the younger people coming out were the smartest people around. And it was quite intimidating, but brilliant infrastructure. And they made a very big difference. They were bold in the way they went and did things. So I'm still friends with them. We still use them, actually. I have terrific admiration for that firm. I really wish I could have the kind of level of infrastructure that they have there within our company. It makes life so much easier, but we're building it. But yes, I think probably the biggest transition for me was just going from lots and lots and lots of supported infrastructure to basically none that I had to create.
Yeah, that had to be a challenge, right? I mean, you all of a sudden you're creating this infrastructure that was, kind of embedded in the culture of the last group you're with, right? So I'm thinking that probably took a little patience, might have created even a little frustration while you're going through that. Am I heading down the right path for that?
I have made many mistakes, Tom. And, it's running your own business is one of those things that it's not just about the business. There's also enormous amounts of personal evolution in it. So just as an example, you mentioned the word culture. Well, within my company, there was me, essentially. So what was the culture there? It was one person. But as we're adding people and growing, you really have to come to terms with what kind of organization do I want to be working in? What kind of organization do I want to be growing? what kind of values do I really want to inculcate in everything that we do? And those are very personal questions that I've spent a lot of time sort of reflecting on, speaking with people about. They're very personal. And actually, you have the opportunity in my position to be able to shape the type of organization that we're actually building. I've been very fortunate to attract some terrific people along the way. I've also had the experience of attracting not so terrific people along the way who sadly are no longer with us. And even that by itself, at these big firms, when you get somebody who's not a good fit, they get quietly sort of shifted to the side of the stage and you never see them again. Here, you have to sort of take ownership and then really actively make choices about whether they stay or not. It's a very, very different experience.
Yeah, but a very important one to be sure. And one of the things that I was researching that I wanted to touch on, because I think this is going to be important to our gurus out there that are listening in, because we've got a lot of entrepreneurs and soon-to-be entrepreneurs. And I noted that, if I got this right, you described yourself as a creator of shareholder value through the concept to commercialization of novel medtech. Can you walk us through what you mean by that and then how it shaped your work at Bruin Biometrics?
Yeah, so we specifically focus on areas of medicine that are chronically deficient in their diagnostic standard, which then has an effect on the clinical outcomes that providers of healthcare want to try and achieve. So I come at this very much from a safety systems perspective. So I had the great fortune of working with a lady called Professor Nancy Leveson at MIT, who wrote one of my favorite books called Engineering a Safer World. Now, I took her safety systems approach, and when I saw Bruin Biometrics, that was exactly the approach that we took. We took a safety systems approach. Now, we focus very much on bed sores, pressure injuries, or pressure ulcers as they're known, which is oftentimes seen as being a deeply unsexy topic, but actually it's a condition that is, if the CDC measured it, it would be in the top 10 leading causes of death. So over 1,100 patients a week die from it. Now, the standard of care that applied was chronically deficient in its diagnostic standard. So what we needed was a different clinical strategy to be able to affect better outcomes, lower health inequalities. And what I'll tell you is that the people at UCLA, University of California, Los Angeles, particularly in the nursing school, invented that clinical strategy. And that clinical strategy relies on the use of a biomarker and a measurement technology applied at the bedside to make nurses more powerful with the information that they've got to act on and change the course of the disease. So it's called the disease in CDC language. I prefer a medical condition, but we can leave the language aside for a minute. The point is, change its course. But when it was invented, it was very much a concept in the mind of the nurse inventor. Now, as you know, because you've done this for such a rigorous way for a long time, you know that taking an idea from somebody's mind to actually having a transformative effect at the bedside is a journey, to say the least. And so what we did was we designed a strategy, which we call our formulas strategy, to take each individual component of what it meant to go from concept to commercialization, adding clinical value all the way along, and alongside clinical value, adding corporate value. In other words, increasing the value of the business such that we'd be able to generate at least on paper returns and then ultimately capital returns back to our investors again. But what it meant was following a process which had 5 very particular steps in it. Now, our goal was and is to become the new standard of care for pressure injury prevention using this clinical strategy. And we're well down that path. But to get there, there are 5 things you've got to do. 1, is you absolutely have to have a biomarker and a technology that does what it says on the tin. Meaning, is the biomarker clinically applicable for what you're trying to achieve? And can it be measured? That's Formula One. But answering that formula, solving that formula, isn't enough. Because then you've got to move on to showing the clinical efficacy of it. So to being able to show not just in the lab, but actually at the bedside, do you actually have, can you generate the right evidentiary standard, which is met by the evidence, so the clinical and economic evidence, that actually allows you to say, yes, I've actually got something clinically useful. And that's not enough by itself. So now you've got the device, you've got the clinical efficacy. Those two things are not enough, because then you actually have to be able to show outcomes. So it's all good doing the work, but then you've got to actually achieve the outcomes. The outcomes that we wanted to achieve and are achieving, we're not doing it, our nurse users are, is primarily incidence reduction. Tom, it was fascinating to me that actually in the world of pressure injury prevention, there was no definition of what prevention actually meant. So together with our clinical partners, we created it as keeping skin intact. So outcome number one is the use of the device at the bedside keeping skin intact, yes or no? Answer, yes, to at least a 92% incidence reduction. That's a great thing. So there were clinical outcomes, then there were health economics outcomes. You should be able to do this, i.e. achieving a better clinical outcome, for less money. Why is down to the fact that within safety systems, if you've got the right strategy, you can drive down resource usage, which practically means use less nurse time. We're deeply respectful of the time that nurses spend at the bedside, and we don't want to add to that waste. We want to reduce the amount of time they're spending doing things that are not useful. So if you get into that magic quadrant in health economics of better clinical outcomes, reduce cost, that's where we wanted to get to. And thankfully, that's where we are. There are a whole bunch of other outcomes that I could talk about, like clinical and quality and litigation, which we can get onto later. But that was formula number 3. So technology, clinical outcomes. Then you've got to get support. And then the support for us came down the path of key opinion leaders around the world. So these are people who write the guidelines. We wanted to get regulatory support. So what that meant was basically, in the form of recommendations, payment from the Centers for Medicare and Medicaid. So actually making sure that users got paid and that we got paid. That's incredibly important. And then, making sure that we could get recommendations. And so we've got 9 of those now, but that was an integral part of the strategy. And then finally, you have to be able to sell and deploy it so that you get the great user experience and bedside experience for nurses, which in and of itself is its own set of challenges. And so those are the 5 formulas that we went out to solve to get us to being the new standard of care.
That's phenomenal, and thank you for that overview. That's really almost a clinic on how to go about it, and I appreciate your walking through it. And I'm going to touch on a couple of those points as we go a little further in our discussion. But you mentioned the how do you sell it, which kind of ties into my next question, because as you mentioned, prevention is at the core of BBI's mission. And I'm just kind of wondering now with that, what's the biggest obstacle, getting healthcare systems to invest in that preventative care, right? That sellable part. How are you going about tackling that at the moment?
So there's 2 aspects to that answer. The first thing that we've experienced is that health systems view innovation as a medical error. So they all operate around protocols, which are long established and they're risk-based. And so the first thing you've got to do is to be able to make absolutely sure that when you're bringing a new clinical strategy, that it's not rejected because of the fact that it's seen as being a medical error. You have to have partners that can actually bring it in under an innovation pathway, so they can safely bring in new innovations, apply it at the bedside, get the results they need, see for themselves that it's safer than what they're currently doing, and then being able to deploy it. That's the first thing. The second challenge, frankly, Tom, is that there's been an awful lot of talk about the movement of health systems and the delivery of care towards prevention. But actually, policy in the overall environment that is the systemic environment still supports treatment. Now, health practitioners are trained to treat. And the idea about preventing something is working in certain areas. And I could point to multiple examples about nutrition, and I could point to examples about, in diabetes, about sort of wonderful work that's going on there for prevention. But in the world of wound care and pressure injury, in fact, wound care gives you the title that you need to know. A lot of it is about treating and caring for the wound. Policymakers have been really frustrated all around the world about moving from a treatment-based paradigm to a prevention-based paradigm. It's not trivial. And so the way that we approached it was, and I'm giving away our secret sauce here, but I think it's important for everybody. The way that we approached it was, we said, if health systems are designed that way, then instead of trying to fight the health system and change it, which you're never going to be able to do as a single company, find a way to work within it, because that's how it works. Okay. So in our case, we were fortunate that there was a biomarker that was developed alongside the technology. People confuse us as just being a medical technology company, which we are, and we're also a science company, because we had to develop the science of the biomarker, which is called subepidermal moisture, or SEM. And the intuition that you should have here, Tom, is that pressure injuries don't magically appear at the skin surface. There's a whole raft of etiological and pathological processes occurring beneath the skin surface that actually result in the injury erupting at the skin surface. But they're all microscopic. And because of the fact they're subcutaneous, even if they weren't microscopic, you shouldn't see them anyway. So what's happening is that we were then detecting a condition, and here was the key for us, that precedes and predicts tissue death. In other words, it's a condition requiring treatment. And there's the key. Now we saw through the data a condition requiring treatment. If you didn't treat it, would result in broken skin ulcers with a known predictive rate. And our device is detecting it. And so now we've got a condition that you can identify that requires treatment, and that fits the paradigm that health systems work within. It also allows us to then apply for payment, because what we're doing is not just doing something what CMS views as being randomly to try and achieve prevention, but rather we're achieving a treatment of a condition that, if not treated, will end up with a particular known result. And that they will pay for, we believe. So that's what we did, and that's how we approached it.
Yeah, that's really fascinating, and I appreciate you're walking us through that, and maybe giving away a little bit of the secret sauce there as well. But you've touched on this a little bit, and we all know that pressure injuries are incredibly costly. So I'm just wondering, in terms of outcomes and dollars, right? What impact has the SEM scanner had on health systems so far, and what feedback are you hearing from clinicians?
The pressure injury costs, we spend a lot of time with health economists.
Mm-hmm.
And one of the things about pressure injury costs is that they're very hidden. They're just sort of rolled up under the hoteling side of the budget, typically, of a hospital. And so they're you could think about the costs as being peanut buttered in. They're sort of smeared in to the overall budget. But actually, when you really break it apart, what you find is that pressure injury costs are largely accrued to the health system, or if they're not accrued to the health system, to the payer. And what that means, so taking it out of economics term, what it means is that pressure injuries are actually a leading driver of infrastructure costs. And when stuff goes wrong, i.e. skin breaks, the amount of cost that a facility actually incurs grows exponentially. So the average treatment cost for a stage 4 pressure injury in the US exceeds $140,000. Now, if that occurred on your watch as a hospital-acquired condition, you pay. You, hospital, pay. And further than that, you're penalized for a 1% Medicare penalty. And if your patient is discharged and gets readmitted within 30 days, that penalty, if it's a readmission because of a pressure injury, is actually 3% of a Medicare ding. And it's a leading cause of litigation. And it drives up costs all over. So just to give you a sense of it, we've been working with a health system in New York, and I'll use some slightly outdated data from 2019, but they developed in their system about 9,900 reportable pressure injuries. That cost them $330 million to try to prevent and then treat those ulcers. Now, if I'm the CEO or CFO of a health system, and I know that my system is incurring a $330 million charge, for which I may not be able to recover all of those costs, that to me rises to the level of urgency. I have to fix this today. Mm-hmm. You asked about what kind of response we get. We have no problem getting in front of CEOs, COOs, and CFOs of integrated delivery networks to discuss this particular condition and the clinical strategy. That's rare for a med tech company to be able to get that level of invitation and access. But it just goes to show you how seriously health systems take this condition. And it shows you how seriously the CFOs and COOs take the costs that come along with trying to prevent and then ultimately treat this condition. It's a really serious problem, to a point where Bill Padula, who's an economist at USC, describes it as being the dominant quality intervention that subordinates all others. The dominant quality intervention, meaning prevention of pressure injuries, subordinates all others because the costs are so big. And at a national level, his numbers show that the US is paying close to $30 billion a year of unnecessary costs. And then within the Veterans Administration, it's another $1.5 billion.
Wow.
Now, I hate to keep harping on about the money because it's so crude relative to the patient experience and the patient safety issues, but both go hand in hand.
Mm-hmm. Yeah, for sure. That's how we measure things. I happen to have a master's degree in health economics, so you're speaking my language with this, so I totally get it. But I want to tease out one of the thing that you mentioned, right? In trying to package all of this, right, from a market access, right, or from a preventative technology, right? That can be a little tricky sometimes, getting the numbers right and all that. So, how did you go about packaging some of that to gain access to those COOs, CEOs of those hospitals, really as kind of a smaller company that probably doesn't have a household brand name like, some of the big boys in this industry have. So that's kind of fascinating. Do you have any insights you can provide our gurus out there as to how you did that?
Work with the right people is the first thing. I mentioned Bill Padula. Make sure that this is what we did. We made sure that we pulled in the experts that we needed as we needed them. So as much as I can sit here in the company and devise a strategy, I also am not hubristic enough to be able to say, I know all the answers, because I don't. And that would be a really disservice to what we're trying to do. So we have put together a panel of the most terrific people who are both clinical and economic and quality and legal. So sort of 4 big areas. And we benefit enormously from their expertise. So we lean hard on them, actually, Tom. So that's the first step. The second step is I love to be able to put myself in the shoes of the person I'm speaking to and listen hard. So I try and go in incredibly prepared. This is the consulting mindset, by the way. Very prepared. So when I go into a CFO's office, I know I've probably got about 15 minutes of time. I've got to be able to connect with that person in a way that I've done my research beforehand. I know exactly what their situation is, at least as much as I can gather from available information. And then be able to communicate in a way that shows I understand their situation, that I understand how oftentimes frustrated they are about the fact that this is still persisting, and offering them a solution. And the solution is you need a strategy. You need to do more. So throwing more nurses at it, throwing more dressings at it, throwing more bed surfaces at it, you've done that for decades and you've got the result you've got. It's optimized. You need a different strategy. And here it is. And so that conversation typically tends to take about 10 to 15 minutes. They then don't get involved in the details, quite rightly, but then they allow us to work with team members who do go into the details. It then translates into oftentimes a very clinical conversation, which is good because we do both. We go in parallel of working with the clinicians as well as working with leadership. So we're not leaving anybody behind on the journey. And that's been so far quite successful. We've had some really good results that way.
Yeah, that's fantastic. That makes total sense. But it strikes to another question with me because, you mentioned your 5 steps in design earlier, right? And then now the health economics. None of that is inexpensive to do, right? So from a fundraising standpoint, I'm just kind of curious, have you found this type of packaging this information, talking about those steps, to be helpful when you're out trying to raise investor dollars? Maybe you can give our gurus out there some insights and strategies about how you went about some of that and what you learned along the way.
Right at the beginning of this, I said that it's very rare in life you can come across problems that are really big and solvable.
Mm-hmm.
And I approached this with a firm sense of belief that those two things were true. So actually, thankfully, the first belief turned out to be true based on the data. It is a very big ubiquitous problem. That's true. And I now know because of the data that it's a solvable problem. So those are good things. That's a helpful construct for an investor. Why? Well, because they're looking at the investment thesis. So their investment thesis is, look, I'm going to push a bunch of money into this on risk. So there's a high degree of risk, and the weighted average cost of capital for this was very high at the beginning. And there's a bunch of developmental, regulatory, and commercial risk that has to be reduced over time. And I want to be able to get a return for it. So you've got to then make sure that your hurdle rate that they set gets met. So there's this game that gets played between the valuation of the organization that you're raising money for and making sure that you're trying to give investors a return for their money. So not selling too much on the upfront and making sure they get a return on the back end. There's sides to it, but truthfully, it's more art than it is science. The way that we did it was that we were initially funded by ultra high net worth individuals. And thank God for them, because had it not been for people who were higher in their risk tolerance, this would never have gotten off the ground. And as we decreased the risk curve, so our weighted average cost of capital went down, we were then able to attract strategic investors. So we had a strategic investment in 2020, which put a valuation on us at the time, and they put in like 26 and a bit million into the business at that time. and over the next 2 years. And, that added to the ultra high net worth individual funding. So that was all very beneficial. So you're quite right. I mean, your very first statement was it's very expensive to do this, and you're on point. I mean, it really is. We also took the view that this was not a niche play, but rather was going to be a solution that actually could apply here in the US, but also outside the US. It's global because this problem exists globally and it's perpetual. So in our financial model, what we do is that we've got all of our market sizing in the total available market. And it's not a once and done situation. It's perpetual because every single patient that comes up at the door of a facility is assessed for their risk. So the total available market is annual and it goes out into the future as well, perpetually. So from an investor perspective, that's a very attractive thing.
Yeah, that's helpful. And I think by taking some of those steps that you've had, right, in terms of, the studies, the engineering, I think that might help translate so the investors kind of go, well, they're checking a lot of these boxes, right? Is that heading down the right path?
You're 100% right. The amount of diligence that gets produced in a set of documents that then they help make decisions against is very extensive. So all of our clinical work was incorporated. We now have around 200 pieces of clinical evidence, of which about 80 of those are peer-reviewed publications. We've done all of the health economics work very extensively and published all of those too, in collaboration with people like Bill Padula. That's not enough though, I will tell you, because actually also the investor groups are also looking at, well, you've got this great invention, have you protected it? So there's all of the IP work that goes along with it. Right now, we're sitting on about 500 and a bit issued and pending patents globally on these inventions.
Wow.
So there's a huge amount of protection about the work that's gone on that all gets integrated into the package. And I will tell you, for all of the listeners of this, don't be at all surprised about the level of detail that an investor group will apply as they're doing diligence. These people are whip smart and they've been around the block many, many times. They've seen all of the pitfalls and they ask questions that are detailed questions.
Yeah, that's so spot on. We've had a couple of gurus on that have talked about intellectual property for medtech and protecting it and creating those files. And I'd encourage our listeners to go seek those out because it is very detailed and it does apply to raising money, right? Because if you're an investor and you're going to write a check with a lot of zeros on it, you want to make sure that somebody in some other, country outside the US or wherever can just go steal it, right?
That's exactly right.
Yeah. I love that. Very good advice. So Martin, looking at your background and talking with you today, I mean, you've led teams through every stage of the product life cycle. And I'm wondering, for our gurus out there, from your perspective, what's the most overlooked part of that journey, right? What can medtech startups be aware of so they don't miss something or do something that might set them back? Do you have any thoughts for us there?
I have a really definitive and strongly held bias that inventions that stay within the echo chamber of engineering departments are doomed to failure. And so therefore you absolutely have to do what Steve Jobs always advocated for, was start with the customer and work your way back. So whatever you do, beg, borrow, steal to be able to get in front of your prospective customers and really understand the jobs they're trying to satisfy, the constraints they operate in, and the opportunities that occur and exist in their particular environment. You will live and you will die based on whether your customer wants, loves, and trusts what you've done. So you can be as much of a guru about engineering as you want to be, but unless you got that customer front and center in your mind, you're doomed to failure.
How that's so spot on. But from your perspective, just as a follow-up, your product is, uses a lot of technology. It's very innovative. When you go out to see that customer, is there any concern about maybe, just sharing too much and getting information out there that somebody could run away with? Or is it just selecting the right partners, or how do you go about protecting what you're going to show them?
That's a balancing act, Tom. We've already got people in the marketplace trying to copy what we're doing, and we're sufficiently far ahead with regard to the regulatory environment and also our IP protection that we have some ring fencing around what we've done. But there's some really smart people out there, and with the big enough opportunity, we are fully expecting to have copiers and fast followers. I say it's a balancing act because on the flip side, I am genuinely motivated by trying to eliminate unnecessary patient suffering. I hate it, and I hate the systemic waste that comes with it. So there's an advantage, actually, of having others do what we do in the form of increased patient safety, and that's a good thing. My investors, on the other hand, also have to be paid back and given a return. So I do actively watch out for and protect our inventions because we've spent a lot of time and effort and money on them. Now, in terms of sharing, there's a choice even in doing podcasts like this. Am I sharing too much information that really should be kept more internal? I do debate that in my own mind. And, we present a lot at conferences around the world as well. Mm-hmm. But I don't know how to make a positive impact on things without sharing the information. Mm-hmm. And I have a really strongly held belief that this is too big of a challenge to try and solve by ourselves. But actually what you need is to be able to motivate a huge number of people in the direction of eliminating this very preventable condition. And if that means taking the risk to overshare information, I would prefer to do that for the benefit of patient safety than keep it so closely held to my chest that feels safer, but actually doesn't have the effect that I need it to have in the health systems. Mm-hmm. I take the chance.
Yeah. And I think it's a good chance, right? Because I think for the most part, people are good out there and want to help, for that same patient safety mission that you're on. So I think that's very meaningful. So Martin, this seems like a really exciting time for you and your team at BBI. What does the future hold? Where are you and your team going from here?
It is an exciting time. We grew at about 70% last quarter, and we're up about 140% since November of last year. And we've got a number of incredible customers that are around the US and outside of the US. So we're very fortunate on that front. Where we are going is very much grounded in what I said right at the beginning, which is that we're trying to achieve a new standard of care. The new standard of care has to, in this instance, disrupt and hopefully retire the old standard of care. And the old standard of care was very much risk-based, where we've taken a biology-based approach, and I will go with biology every day over risk. The other thing is that the old standard of care is a one-size-fits-all care model, meaning it doesn't matter what kind of patient you are, you're always going to get exactly the same protocol applied. Now, I know, based on our data, that is intellectually bankrupt. And what I want instead is to be able to equip nurses with the information that they need to tailor care for a particular patient at the bedside. Now, you can't do that and expect the nurses to go through the intellectual clinical calculus at the bedside in real time. That's deeply unfair. So what we've done is we've instead invested in data, because data allows for machines to be able to give nurses the information they need based on a particular patient profile, and then be able to, using the facilities protocol, inform the nurse at the bedside that for George, who's got a fractured neck of femur and doesn't have any redness on his left heel, but the scanner is saying you've got a problem, that nurse knows exactly what to do for George. But if you then have a different patient, Jane, who is coming in for a different condition, cardiac condition, let's just say, and Jane has got a completely different patient profile, that she ought to be able to get a different type of protocol applied to her. And what happens is you end up with tailored care, specific to the individual, that, and here's the key, means that nurses are doing less.
Mm-hmm.
Why? Because the data shows you just do these 3 things and that gets you the same outcome, not do more to just chuck everything you've got. And I much prefer that. That for me is about systemic efficiency. And so where we're taking this is way down the path of data. We have a digital platform. It's designed to be able to be a personal assistant so that at the bedside, the nurse knows what to do. And then also it reduces all of the paperwork burden, because paperwork should be gone, should be all automated. And there's enough movement towards generative AI and the use of tools to take that admin burden out of the day-to-day clinical and managerial processes. I love that. I think it's very exciting, frankly. So that's where we're going.
Oh, that's outstanding. And it'll be fun to watch you and your team and how this all develops, because I do believe that it is. I think you're very right. What you said at the top of the show is it's a very underlooked or less awareness around this particular aspect of our industry. So I commend you and your team for what you're doing. So Martin, first of all, I'd like to acknowledge and thank you for the time and preparation and the time that you spent with us today to be our guru. If somebody wants to learn a little bit more about Bruin Biometrics or you, how do we do that? Is there a website? Are you on LinkedIn? How do we learn more?
Tom, I'm going to say again that I feel slightly embarrassed about being included in the guru set, but I will definitely take it. Believe me, it's very pleasurable to be in this. So thank you for that.
100%.
And in terms of getting in contact, I'm everywhere. And we're everywhere. So certainly on the website is sem-scanner.com. And then on LinkedIn, it's under Bruin Biometrics. And I'm also on LinkedIn. And I get LinkedIn messages every day. I personally love working with my medtech peers. I really genuinely mean that. And so people should feel free to reach out to me if they've got questions.
Well, that's fantastic. So Martin, once again, thank you so much. It was a delight and a great conversation. We appreciate the insights that you brought for us today.
Tom, thanks very much.
Thank you. Thank you for listening to MedTech Gurus. I am Sylvester Harris, your MC. If you want to learn more about Term and his consulting services, you can go to www.pctmedical.com or email Term at term@pctmedical.com. Now, I can be reached at Sylvester Harris, that's SylvesterHarris 5048 @gmail.com, and I'd be pleased to discuss any voiceover work that you may want for your company or broadcast. Hey, thanks so much for listening, and catch us on the next episode of MedTech Gurus.